That looks better. And PowerPoint. Okay, so Sheila, can you see the PowerPoint okay?
Yes.
Okay, thanks. All right, so today we're going to talk about the neck, which you've already started dissecting on Tuesday, and you're going to finish up your dissection today. There are several layers of fascia in the neck that divide the neck up into a number of different compartments. So it's similar to what we saw in the limbs, in the upper limb, where the muscles of the brachium and antebrachium were divided into muscular compartments. And in particular, down in the hand, we had lots of compartments like the thenar compartment, hypothenar compartment, et cetera. So we have a series of fascial compartments here in the neck. So this is a simplified schematic showing the different compartments and identifying the different layers of fascia that surround them. And you're actually going to see this same picture pop up several times. As I introduce each new compartment, this picture will pop up again, and I'll come back and review. So I'm going to start out by talking about what's called the investing fascia, which is a layer of fascia that goes all the way around the entire neck, both the anterior surface, lateral, and posterior surfaces. And it's represented in this picture by this purple line. The light tan line on the very outside, that's supposed to represent the skin. And then that purple line that goes all the way around the neck represents this layer of what's called investing fascia. So it's similar to the deep fascia that we saw in the upper limb surrounding the muscular compartments. The investing fascia actually has muscles embedded in it. So some of the more superficial muscles in the neck are actually embedded within this layer of investing fascia. So anteriorly, which is down at the bottom of the slide, you see that the sternocleidomastoid muscles on both the left and right sides are actually embedded within this layer of investing fascia. And then posteriorly in the back of the neck, the trapezius is surrounded by investing fascia. So let's take a look at this from an anterior view. And you may not have actually recognized this layer of fascia as you were doing your dissection on Tuesday, but you actually had to remove it or cut into it in order to access a lot of the structures that you were looking at. A lot of the fibrous tissue that you had to remove in order to access some of the nerves in the neck and to sort of clean off the surface of the sternocleidomastoid, you didn't realize it, but what you were removing was investing fascia from the surface of the muscle. So it lies just deep to platysma. So you can see in this Netter painting a little bit of platysma, which is even more superficial because it's literally in the skin. And then just deep to the platysma is this layer of investing fascia. And then over on the right side of this particular figure, all of that's been cleaned off. And you see that sternocleidomastoid and trapezius. We've talked a lot about the trapezius before, back at the very beginning of the course, but we haven't really talked much about sternocleidomastoid. The name of the muscle actually tells you the attachments of the muscle, which is true of a lot of the muscles of the neck, which some of you probably noticed that on Tuesday in lab. Sterno is kind of obvious. It has part of its origin on sterno. The prefix cleido may not be familiar to you, but that's the Latin word for the clavicle. So the origin of the muscle is on both the sternum and the medial end of the clavicle. And then the last part of the name tells you the insertion of the muscle. So it's inserting on the mastoid process just behind the ear and as part of the temporal bone. It's innervated by the accessory nerve, which is cranial nerve 11, which we talked about on Tuesday. So both trapezius and sternocleidomastoid, these two muscles within the investing fascia, are both innervated by the accessory nerve, cranial nerve 11. The sternocleidomastoid has a number of functions all involved in movements of the head and neck. The functions may be a little bit difficult to predict though, because of the angle of the muscle, and because of its attachment on the mastoid process, the movements that the muscle creates may not be immediately obvious. I think what trips people up is the fact that the attachment on the mastoid actually sits posterior to the occipital condyles, which is the pivot point for the head to nod up and down, forward to backward. And also the insertion of the muscle on the mastoid sits posterior to the axis of rotation, which is, that joint that's formed between C1 and C2, between the atlas and axis. So if you use both sternocleidomastoid muscles to pull on the mastoid process, it actually allows you to look up, which may be surprising since the muscle is in the front of the neck. It might be surprising that it causes you to look up, but what's happening is it's pulling on that mastoid process that sits behind the pivot point, behind the occipital condyles. So when you pull down essentially on the back of the skull, it pulls the back of the skull down and lets you look up. If only one of the sternocleidomastoid muscles is working, it's going to rotate the head to the opposite side. So if the left sternocleidomastoid is contracting, it's going to pull my left mastoid process forward, which is going to rotate my face the opposite direction. So my left sternocleidomastoid is going to rotate my head to the right, and the opposite of that would be true with the other one. All right, so that's all I'm going to say about sternocleidomastoid, trapezius, and investing fascia. So let's return to this picture of the fascial compartments of the neck. And by the way, I mean, if it wasn't obvious, it didn't occur to me to point this out, but this is a transverse section or horizontal section through the neck. There are actually a couple of layers of fascia that lie at the front of the neck that contain a lot of the important viscera of the neck, meaning the organs of the neck or organs that are passing through the neck, as well as a lot of the arteries and nerves and things that are traveling vertically up and down through the neck. So there's a layer of fascia called pretracheal fascia, which is identified by kind of a orange line in this particular slide. And if you look within that orange line in the pretracheal fascia, we see a whole bunch of structures in here. This gray oval that sits near the back of the pretracheal fascia is the esophagus. Now, in this particular level of this cross-section, this horizontal cross-section, we're cutting through the esophagus. But if we were to slice through the neck a little bit more superiorly, a little bit higher up, we'd be slicing through the pharynx, which is the fancy name for your throat. So both the pharynx and the esophagus are contained within this pretracheal fascia. The other gray oval on the image, so the more posterior one is esophagus. The other gray oval that sits just anterior to that is the trachea. And again, this is a pretty low cross section. This is pretty far down in the neck. If we were to take a cross section a little higher up in the neck, a little more superiorly, we'd be cutting through the larynx, your voice box. So the larynx and the trachea are also both contained within the pretracheal fascia. The yellow gland-like organ, it's got a little bit lumpy texture in the picture. That is the thyroid gland, which if we saw it from the front would look kind of like a butterfly, with a pair of butterfly wings. But here we're seeing it in cross-section and it's wrapping around the trachea. So the thyroid gland is also contained within the pretracheal fascia. And then anterior to the thyroid gland, you see a bunch of these little flat red structures, which represent cross sections through the strap muscles in the front of the neck, what are sometimes referred to as infrahyoid muscles. So that would include things like omohyoid, sternohyoid, sternothyroid, thyrohyoid. All of these muscles are also contained within pretracheal fascia. So pretracheal fascia contains pharynx, esophagus, larynx, trachea, thyroid gland, and all of the infrahyoid muscles like sternohyoid and so forth. Now, just lateral to that pretracheal fascia, you see there are two other small compartments surrounded by fascia. And in this particular diagram, they're gray layers surrounding these structures. These are called the carotid sheaths. And there are two of them. There's a carotid sheath on the left, and that sits just to the left of the pretracheal fascia. There's a carotid sheath on the right. And the carotid sheath contains the internal jugular vein, the carotid arteries, and I say plural because that means the common carotid artery, but also after the common carotid bifurcates to become internal and external, those are also contained within this carotid sheath. And then if you look really closely, you see there's a little yellow dot inside there as well. That's the vagus nerve. So internal jugular vein, the carotid arteries, and the vagus nerve are all packaged together in a fibrous sheath called the carotid sheath. Now, if some of you actually found your internal jugular vein and actually kind of exposed it and identified it, it's possible that you've already cut into the carotid sheath and may not have realized it. Once again, you may have just encountered a lot of stringy fibers material as you were trying to clean up some of these other structures. And those are just remnants of these different sheaths. So let's take a look at a couple of different views of the pretracheal fascia and the carotid sheath. This is one of Netter's paintings showing a lateral view of a fairly deep dissection of the neck. And I actually added the colors on here just, in Photoshop to try to show the boundaries of these different layers of fascia. So all of the pink area is supposed to represent the structures contained within the pretracheal fascia, and you see it's labeled here on the left. So even the muscles that sit superior to the hyoid bone, so things like mylohyoid and anterior belly of digastric, are contained within here. The hyoid bone itself, the larynx, which in this case, the arrow is actually pointing to the thyroid cartilage, which is one of the structures that forms the larynx. The thyroid gland and the trachea. And then there's a little note here that says the pharynx and the esophagus are not visible. So the pharynx or throat would be, kind of buried in here. And then the esophagus is also kind of hidden from view in this particular view, but those would also be contained within that pretracheal fascia. And then on the right are labels for different structures within the carotid sheath, and that's represented by this green outline. So we've got internal and external carotid arteries, which are branching off of the common carotid artery. Vagus nerve is just barely visible in there. And then in this particular dissection, when Netter painted this, he had already removed the internal jugular vein. But just remember that that would also be present within that sheath. Here's a little different way of looking at it using the same color scheme with a pink or purple line surrounding the structures within the pretracheal fascia, and green lines showing the structures within the carotid sheath. So pretracheal fascia, again, goes all the way up to the mandible and encloses things like digastric muscles and mylohyoid. Here, they're collectively just called suprahyoid muscles because these are muscles that are superior to the hyoid, but that includes mylohyoid and digastric. And then all of the infrahyoid muscles that sit inferior to the hyoid. So omohyoid, sternohyoid, sternothyroid, thyrohyoid, all of those things. And then again, we can see the larynx here, inside the thyroid cartilage. You can see some of the rings, the upper rings of trachea that are included in there. And once again, things like pharynx and esophagus are hidden from view in this particular image. And then just lateral to that pretracheal fascia on both sides, we have the carotid sheath containing the different carotid arteries. So common carotid, internal carotid, external carotid, as well as internal jugular vein and vagus nerve. The last fascia compartment that I want to talk about is one that we won't see right away. We won't really see it in this unit of the course, but after the third exam, we're going to do some additional dissections in the head and neck. We will actually get a better view of this last muscular compartment or this last fascia compartment. It's called the prevertebral fascia or prevertebral compartment. And it's a little bit of a misnomer because the prefix pre usually means before or in front of. So prevertebral suggests that it's a bunch of stuff that sits anterior to the vertebrae. And that's not really true, because if you look very closely here at this green line, you'll see that includes the cervical vertebrae themselves, includes a few structures that do in fact sit anterior to the cervical vertebrae. There's a couple muscles that sit on the front of the cervical vertebrae, but it also surrounds a lot of the deep muscles in the back of the neck. And so there's a lot more structures that sit posterior to the vertebrae than anterior. So like I say, the name's a little bit confusing. But this is what that prevertebral compartment looks like. You don't really see the fascia in this case, but we do see what the prevertebral compartment or muscular compartment looks like. And so what's happened in this particular dissection is that the head has been removed, the skull's been removed, and all of the anterior structures of the neck have been moved out of the way to expose the cervical vertebrae, vertebral column and the muscles associated with it. And we actually are going to do a dissection very much like this after the third exam sometime. I forget exactly where it falls, but we're actually going to disconnect the occipital bone from C1, from the cervical vertebral column. And once you've detached the skull from the vertebral column, you can actually bring the whole head forward, including all of the pretracheal and carotid stuff, all of this, the organs that are contained within the pretracheal fascia, carotid arteries, jugular veins, vagus nerve, all of that stuff. You can reflect the whole head with all of that neck stuff attached. You can reflect it forward and literally lay the person's face, or lay their head face down on their own chest, and then see the cervical vertebrae exposed exactly like you're seeing in this picture. So you see the bodies of the cervical vertebrae in here. This is actually C1 up at the very top. C1 has especially wide transverse processes, which is one way you can recognize it. And then C2 just below that, and then continuing all the way down. This view even includes the first couple of thoracic vertebrae down here. There are a pair of muscles that sit on the anterior surface of the vertebral bodies, which don't have to worry about memorizing them right now, because we'll come back and revisit this later when we actually do that dissection after the third exam. But they're called longus colli and longus capitis muscles. There's also a group of muscles that sit laterally that originate on the transverse processes of the cervical vertebrae and then have their insertion on the first two ribs. These are all called scalene muscles. And we'll come back and see these later at another time. So everything I just talked about was talking about how anatomists group different structures in the neck together in terms of these different fascial compartments that they sit in. But when you do a dissection of the neck, normally it's not possible to dissect an entire fascial compartment all at once. So when we dissect the neck, we usually approach the neck in terms of different triangles that are formed by different structures in the neck. So the dissection that you did on Tuesday, you started out by looking at what's called the posterior triangle, where you would start superficially and work your way deeper, looking for structures that sat either on the sternocleidomastoid muscle or even posterior to the sternocleidomastoid. And then later in lab on Tuesday, you turned your attention to what's called the anterior triangle, which are all the structures that lie anterior or medial to the sternocleidomastoid. And you're going to continue that and finish up the anterior triangle dissection today. So the whole neck is divided into these two large triangles: posterior triangles that sit posterior to sternocleidomastoid and anterior triangles that sit anterior. And this is just the way that anatomists have dissected the neck for decades. They start with one triangle and then move on to the other, just because it's more convenient to dissect it that way. I think your dissector may subdivide these triangles even further, especially the anterior triangle. Your textbook might also get into some really nitpicky, smaller triangles. Like the anterior triangle is subdivided into a submental triangle under the chin, a muscular triangle, a carotid triangle, and a couple of other triangles. I don't care about those tiny subdivisions of triangles. So if you're seeing that in the dissector, don't waste a lot of time trying to memorize the boundaries of these little smaller triangles. They don't really have any significance anatomically. So I want to walk through the approaches to the different triangles, and this is going to parallel more what you've actually done in dissection. So I'm going to start with the posterior triangle of the neck. So structures that are either sitting right on the sternocleidomastoid or sitting in that little triangular area just posterior to sternocleidomastoid. And the main thing that you see here that we were trying to find on Tuesday were branches of what's called the cervical plexus. I'll come back and talk a little bit more detail about the cervical plexus a little bit later in today's lecture, but it's basically just a group of sensory nerves derived from the first 4 cervical spinal nerves. So C1 through C4 all contribute to this thing called the cervical plexus. And you can see 4 branches of the cervical plexus here. They all seem to originate from a point at the back of the sternocleidomastoid, what's known as the nerve point of the neck. And they all kind of seem to radiate out from that same starting point. There's a lesser occipital nerve, which you can usually recognize because it runs right along the posterior surface of the sternocleidomastoid muscle. We saw 1 or 2 of those in lab on Tuesday. There's a great auricular nerve, which runs vertically on the outside of on the outer surface of sternocleidomastoid. And it's usually running with a vein. There's a vein called external jugular vein that also runs vertically along the sternocleidomastoid. So if you had that vein on the outside of the muscle, you might have the great auricular nerve running with it. The transverse cervical nerve crosses the sternocleidomastoid going from back to front. It's actually traveling towards the anterior part of the neck, and it's a sensory nerve to the skin on the front of the neck. And then this particular label here says supraclavicular nerve with just 1 N at the end, but it really should be plural. It should be nerves, so it should be 2 N's, indicating a plural. There are multiple supraclavicular nerves that kind of radiate out towards the clavicle, and they actually are supplying sensation, or they're responsible for sensation to the skin in the lower part of the neck, basically where the neck meets the thorax, right around the clavicle. There are some deeper structures that can be visible in the posterior triangle. In this particular case, when Netter painted this, he reflected the sternocleidomastoid out of the way so you could see these things more clearly. But a lot of these are pretty challenging to try to find in the neck. Some of these are branches that we already talked about. You're just seeing them a little bit deeper under the sternocleidomastoid. So great auricular is the one that runs up along the outside of sternocleidomastoid, runs along with that vein. Lesser occipital would be running along the posterior border of sternocleidomastoid. Some of the others have been removed here. So transverse cervical and suprascapulars have all been cut off here. There is another nerve that's visible back here in the posterior triangle, which is much deeper, and that's the accessory nerve, cranial nerve 11. And I think I did find that on one cadaver. It's very tricky to find because there's a really good chance that we destroyed it way back on day 1 of dissection, or day 2 maybe. The accessory nerve exits the skull. Anybody remember what foramen it comes out of? Somebody said it. Shout it out. Jugular canal, right? Cranial nerve 11 comes out the jugular canal. It lies deep to the sternocleidomastoid, which is hard to tell here because that muscle's been reflected, but it's actually innervating sternocleidomastoid. And then it continues posteriorly through the neck. And right here, you see the sternocleidomastoid entering into the deep surface of the trapezius. And the reason I say that we may have destroyed it way back on day one is because as soon as we detach the origin of trapezius, there's a very good chance that we cut this nerve. So if you're lucky in your cadaver, you may actually see it kind of emerging from under sternocleidomastoid and then continuing towards the back. The one cadaver I found it on, I could actually grab the nerve and wiggle it and look behind the neck, and I could actually see what was left of the trapezius moving up and down as I wiggled the nerve. So I could confirm that that's really what it was. Some of these other structures we're going to come back to and see later, so you don't have to worry about them right now. We'll do a deeper dissection of the neck right after this next exam. There's a couple of arteries here, transverse cervical artery and suprascapular artery, that are originating off of the subclavian artery. I doubt anybody saw these in lab on Tuesday, and you're not going to go looking for them again today. So don't worry about these right now. We'll come back and talk about these more when we do a deeper dissection of the neck. But they can be visible in the posterior triangle if you look deep enough. You might recognize the name of one of these, suprascapular artery. That's the artery that went over that ligament on the superior border of the scapula. Remember, the army goes over the bridge. It's actually coming from subclavian artery in front of the neck and then travels posteriorly to go over that notch on the scapula. Also, if you were to go very deep in the posterior triangle, which I don't think you needed to do in Tuesday's dissection, you come to the scalene muscles that I showed you on an earlier slide. You know, when we were looking at that prevertebral area, there were scalene muscles connecting the transverse processes of the cervical vertebrae to the first couple ribs. They're visible over here. And again, when we do a deeper dissection of the neck, you'll be able to see these more clearly. Whoops. One of the interesting things about the scalene muscles is that the branches of the brachial plexus actually pass between two of the scalene muscles. There's an anterior scalene and middle scalene muscle, and the trunks of the brachial plexus, superior, middle, and inferior trunks, actually exit the neck. You know, they pass between those two scalene muscles. It's kind of cool to see it, but you know, you won't see it right now. We'll come back to it later. Now here is the anterior triangle of the neck, which you started dissecting on Tuesday, and you should finish up today. And this is just kind of an overview slide showing some of the landmarks that are visible, as well as two different groups of muscles that you started to dissect on Tuesday. So some of the bony and cartilaginous landmarks include, of course, the mandible, the mastoid process that sits right behind the ear. That's the insertion point for sternocleidomastoid, which is cut on both sides of this figure. So there's the cut end of sternocleidomastoid. And here it is again on the left side of our patient. The hyoid bone, which is kind of hard to see in the cadaver, but you can feel it. And it's where a lot of these muscles converge. A lot of them have their attachment on that hyoid bone. Just inferior to the hyoid bone is the thyroid cartilage, which I mentioned before. It's one of the structures that forms the larynx or the voice box. The thyroid cartilage has a prominent bump on its anterior, of the laryngeal prominence of the thyroid cartilage. So it's part of the thyroid cartilage. And that's the anatomic name for the Adam's apple, just where that cartilage protrudes anteriorly. And we'll see a little bit later in the course, in a couple of weeks, we'll see how the size of that laryngeal prominence is related to the depth of someone's voice. It's the size of that prominence. It's one of the things that dictates the length of the vocal cords, which controls the pitch or the frequency of the voice. There's another cartilage on here that you should look for today if you didn't see it on Tuesday. Just inferior to thyroid cartilage is something called the cricoid cartilage, which is essentially the first ring of the trachea, but it's modified. It looks a little different from the other tracheal rings. And then the rest of the trachea then begins just below the cricoid cartilage as a series of cartilaginous rings. And then there's the thyroid gland kind of wraps around those first couple of tracheal rings in the front of the neck. The slide also shows two different groups of muscles. It doesn't show the specific names. I'll get into those in a minute. But the muscles in the front of the neck are grouped into two different groups. There's a group of muscles called suprahyoid muscles. So just meaning superior to the hyoid, basically between the hyoid bone and the mandible. And then there's a group of much longer muscles called infrahyoid muscles that lie inferior to the hyoid bone. And they're connecting the hyoid bone to the sternum, the thyroid cartilage, even one connects to the scapula. The infrahyoid muscles are also frequently referred to as the strap muscles of the neck because they're all basically just long, straight bands of muscle. So this slide is focusing only on the suprahyoid muscles. So in other words, the muscles that sit superior to the hyoid bone. We've talked briefly about the digastric muscle before. It's a muscle that has two distinct bellies or two distinct heads. The anterior belly connects the inside of the chin, the inside of the mandible, to the hyoid bone. There's also a posterior belly that then continues from there back to the mastoid process. So it's essentially connecting the mastoid process to the hyoid bone. The two different bellies of digastric function very differently and actually have completely different innervation. The anterior belly actually pulls down on the mandible to help you open your jaw, and therefore it's considered a muscle of mastication because it's moving the mandible. And it's innervated by V3, mandibular division of trigeminal, which is what's responsible for innervating all of the muscles of mastication. I'll come back to the posterior belly in just a minute. There's another muscle that lies deep to the anterior belly of the digastric. This is called the mylohyoid muscle. And it has its origin all along the inner surface of the mandible. There's actually a ridge on the inner surface of the mandible or medial surface of the mandible called the mylohyoid line. And that's the origin for this mylohyoid. It then inserts into the hyoid bone. And it also, it functions basically the same as the anterior belly of the digastric. It's pulling the mandible down towards the hyoid bone to help you open your jaw. And it's also innervated by V3, mandibular division of trigeminal nerve. Mylohyoid. Over on the other side of the slide, I intentionally split these muscles up, labeled some on the left side of the slide and some on the right side of the slide. The muscles on the right side of the slide are also suprahyoid muscles, but the two that are shown on the right side of the slide are both innervated by cranial nerve 7, facial nerve. We talked about these briefly on Tuesday when I was talking about the cranial nerves. So remember that cranial nerve 7, the facial nerve, exits the skull through a foramen called the stylomastoid foramen. It's a foramen that sits right between the styloid process and the mastoid process. And right at that point, the facial nerve is lying between the two muscles shown on the right side of this slide. The stylohyoid muscle originates on the styloid process and inserts directly on the hyoid bone. The posterior belly of the digastric originates on the mastoid process and also connects to the hyoid bone. So the facial nerve, cranial nerve 7, is actually sitting in the stylomastoid foramen right between these two muscles. So it's not surprising that the facial nerve then would actually be the nerve that innervates these two muscles because they literally sit on either side of the nerve right when the nerve comes out of the skull. Both of these muscles are simply pulling up on the hyoid bone. So these muscles can't open the jaw. They don't actually attach to the mandible. They're simply connecting different parts of the skull to the hyoid bone. So they actually help elevate the hyoid bone, which is something that happens during speech and also during swallowing. Now here are the infrahyoid muscles or strap muscles, the muscles that lie inferior to the hyoid bone. And I think most people at least started identifying these on Tuesday. So we have a muscle called the omohyoid, which is probably the hardest one to remember because nobody knows what omo means. But I think I told a few people in lab on Tuesday that omo actually means shoulder in Latin. I've always been kind of fascinated by this muscle because it originates on the scapula, right on the superior border of the scapula, very close to that little notch on the superior border of the scapula. And then the muscle comes from the scapula towards the front of the neck and then makes a turn. Notice it has kind of a tendon in the middle of it. That tendon is actually held to the clavicle by a sling of fascia. So we've got something called the posterior, or excuse me, inferior belly of omohyoid originating on the scapula and kind of traveling forward to the front of the neck. And then when it passes through that sling, the sling acts kind of like a pulley and allows the muscle to change direction. And so then we have what's called the superior belly of the omohyoid that then continues up to the hyoid bone. So omohyoid literally means shoulder to hyoid. It connects the scapula to the hyoid bone. And it's not going to really do much of anything to the scapula. You've got lots of other much bigger muscles that are going to move the scapula around. So I can't imagine trying to move your scapula with just your omohyoid muscle. Mostly it's involved in pulling the hyoid down. And it turns out you get a whole bunch of muscles that all pull down on the hyoid bone. That omohyoid is the most lateral of the muscles that connect to the hyoid bone. Just medial to that is one called sternohyoid. This one's a little easier to remember because the name literally tells you its attachments. Sternohyoid connects the sternum to the hyoid bone. And it's also going to pull down on the hyoid bone. Over on the other side of the slide, the right side of the slide, are a couple of deeper muscles. Some of you cut sternohyoid, which is fine. The book tells you to do that. But I told a couple people, if you can just lift up on the sternohyoid without cutting it, you can usually see these deeper muscles just fine without actually having to cut it. But you can see in this painting, Netter cut both the omohyoid and the sternohyoid down here to reveal the deeper muscles. So there's a muscle called sternothyroid, which connects the sternum to the thyroid cartilage. And then almost immediately, there's another muscle that begins at that same point called thyrohyoid. So sternothyroid inserts on the thyroid cartilage, and right where that one inserts, there's another one that originates called sternothyroid that then connects, thyrohyoid. See, I get myself tongue-tied talking about these muscles. Thyrohyoid that then continues from thyroid cartilage up to hyoid. That admittedly, the names are very challenging because they all sound the same. But if you really stop and think about them and say them very slowly, they're all just telling you the connections. They're telling you the origin and insertion. And in the case of these infrahyoid muscles anyway, the origin always comes first, the insertion comes second, and the origin is always lower and the insertion is always higher. So omohyoid going from shoulder to hyoid bone. Sternohyoid from sternum to hyoid bone. Sternothyroid from sternum to thyroid cartilage. Thyrohyoid from thyroid cartilage to hyoid bone.
Seems like origin is lower, insertion is always higher.
In the case of these strap muscles, yes, origin is lower, insertion is higher. And origin is the first part of the name, insertion is the second part of the name. The infrahyoid muscles that I just listed. Let's see if I can do this without getting myself tongue-tied. Omohyoid, sternohyoid, sternothyroid, thyrohyoid. Those four are all innervated by a nerve you've never heard of before, but we're going to try to find it today in lab. There's a nerve called the ansa cervicalis. Literally means the loop of the neck. It's a nerve that is derived from the first three cervical spinal nerves, C1, C2, C3. And if you find it, you see where it gets its name. It actually forms a big loop that dips down into the neck and sits right in front of the jugular vein and the carotid artery. But it's a very delicate little nerve, so it's really easy to destroy. So, you know, I'll be happy if we find one in the lab today, without destroying it. I'll help if people need help. I'll come back and show you where this nerve is coming from in a minute. I've got a picture of all of the cervical nerves and where they go and how they form the cervical plexus, which are the sensory nerves, how they form the ansa cervicalis, as well as a couple of other branches. Now, there's one muscle that I intentionally skipped over when I was describing these infrahyoid muscles because it has a different innervation. There's a muscle called cricothyroid. It's a much tinier muscle. You should be able to see it if you move the others out of the way. And it's connecting the cricoid cartilage, which is the first tracheal ring, to the thyroid cartilage. And we'll see later in the course that it's actually involved in movements of the thyroid cartilage, which is important in actually changing the pitch of your voice. This muscle actually helps you raise the pitch of your voice and to think about how it moves. Cricothyroid is innervated by a branch of vagus nerve. Did I put that on here? Yeah. There's an external laryngeal branch of cranial nerve 10 or vagus nerve that specifically supplies that cricothyroid muscle. So that's the only one on this slide that's not innervated by ansa cervicalis. So I've actually shown you this picture before, looking at some of the nerves in the posterior triangle, but here we're focusing a little bit more on the anterior triangle of the neck. And see if I can point out some of the important features here. You'll be looking for some of these in lab today. I haven't mentioned this in lecture yet today, but we talked about it certainly on Tuesday. The hypoglossal nerve, cranial nerve 12, will be visible in your necks as part of this anterior triangle dissection. You might not remember this from Tuesday, but I mentioned one of the unusual things about hypoglossal nerve is that it kind of dips down into the neck and forms like a little loop that extends down into the neck, but then it turns and goes back up again to go into the tongue. Remember, hypoglossal nerve is the nerve that's responsible for innervating all of the muscles of the tongue. Not taste or sensation, just motor to the muscles of the tongue. And you can usually see this loop extending down into the anterior triangle of the neck. You have to look usually just inferior to the posterior belly to the digastric and the stylohyoid muscle to find it, but you should be able to see that in lab today. There's a couple branches of vagus shown here. These are going to be a lot more difficult to find in lab. You may not see these, but there's an internal and external laryngeal nerves, very tiny, delicate little fibers. So that's why you might not find them because they're very easily broken. The external branch is the one that innervates the cricothyroid muscle that I just talked about on the previous slide. You can see this thing called the ansa cervicalis now. You get a sense for what it's supposed to look like. And it has what we call roots, which is not a great term as far as I'm concerned, because you don't want to confuse it with the roots of the spinal nerve, you know, the dorsal and ventral roots or anything. But there's what's called a superior root, which I don't know if you can even see what I'm circling with the cursor, but there's a superior root here of the ansa cervicalis, which if you were to follow it all the way up high in the neck, that superior root looks like it's a branch of the hypoglossal nerve. It's not. The ansa cervicalis is well, let me back up. Hypoglossal nerve, remember, it's a cranial nerve. Comes out of the brain, exits the skull through its own little canal, hypoglossal foramen or hypoglossal canal. Ansa cervicalis is derived from 3 cervical spinal nerves, C1, C2, C3. So ansa cervicalis is coming from spinal nerves. So these things are completely unrelated to one another. But it does happen that the superior root of the ansa, which is coming from C1, does kind of hitchhike along the hypoglossal nerve for a short distance and then separates from it. So they just kind of join together, travel together for a little ways, and then the superior root of the ansa splits off of the hypoglossal nerve. So that's why it looks like a branch of hypoglossal, but it's really not. And if I find a nerve on one of your cadavers that I suspect might be ansa cervicalis, it is hard to find because it's pretty delicate. But if I find something that I think might be ansa cervicalis, the only way I can confirm that for myself is if I can trace the superior root of it up and see if it comes off the hypoglossal nerve. If I can't see that relationship, then I'll say, yeah, it might be ansa cervicalis, but I don't know, because I can't tell where it's coming from. The other part of the ansa cervicalis, the other side of the loop, is coming from C2 and C3 back here. So it's coming from C1 and C2 and C3, but they then join together to form this loop that dips down in the neck. And it usually sits right anterior to the carotid sheath. So anterior to internal jugular vein and the carotid arteries. Vagus nerve is another one that you'll be able to see in the neck. You'll definitely want to find that today in lab. From the very beginning of today's lecture, I was talking about those different fascia sheaths. I said that the vagus nerve is within the carotid sheath along with the carotid arteries and the jugular vein. So it usually, if you just separate the jugular vein and the carotid artery, you can usually find the vagus nerve sitting right behind them. There's another nerve here that you probably will not see in lab today, but we will come back to it later when we do a deeper dissection of the neck. There's a nerve here called the phrenic nerve that sits on one of those scalene muscles that I was talking about, which you also won't see today. We'll come back and see this, the scalene muscles later, and we'll be able to see that phrenic nerve later. We'll talk in a little more detail about phrenic nerve another time, but it's a really interesting nerve because it's also coming from cervical spinal nerves, specifically from C3, C4, and C5. Travels down through the neck, doesn't do anything in the neck, goes all the way down through the thorax and actually innervates your diaphragm. So it's the nerve that's responsible for breathing. And without it, you stop breathing. So someone who has an injury to the spinal cord above C3, so if someone actually has their spinal cord severed at, say, C2, not only are they going to be quadriplegic, they're going to lose all function of all 4 limbs, they can't breathe either. So that's why you'll see people who've had severe, spinal cord injuries really high up, like around C2, they have to be on a ventilator to push air in and out of their lungs.
Does it come off the long thoracic?
Nope. It's long thoracic does something similar. Long thoracic comes from C5, C6, and C7, and then runs down the side of the thorax. This one comes from C3, C4, and C5. So it's close. And then it runs down along the scalene muscle deep in the neck and then continues into the thorax, inside the thorax. It actually runs along the pericardial sac surrounding the heart in order to get to the diaphragm. All right. This is a kind of overwhelming slide when you first look at it. But This is attempting to summarize many of the nerves of the neck. In fact, it doesn't even show all of them because vagus nerve is not on here. But many of the other nerves of the neck that I've been talking about this morning or this afternoon are on here. If you approach this slide systematically and understand what it's trying to show, then it becomes a little easier to follow, what it's actually trying to depict. So first of all, it's very schematic looking. There's no attempt to make anything realistic here. That very flat, kind of pale yellow oval up there where it says LO and GA, that flattened oval thing is supposed to represent the base of the skull. And then all of those little rectangles that are also in kind of a pale yellow color, those are the cervical vertebrae from C1 actually all the way down to the T1 vertebrae. And then what you're seeing are spinal nerves exiting the vertebral column at the first, actually the first 9 levels. So we've got C1 through C8 spinal nerves, and then even the T1 spinal nerve. So exiting through their various intervertebral foramina between the vertebrae. In fact, remember the C1, the first cervical spinal nerve, actually exits between the skull and the C1 vertebra. So we've got a bunch of spinal nerves coming off of the spinal cord and exiting the vertebral column. And then notice there's a vertical dotted line right around where those spinal nerves are exiting between the vertebrae. And if you look way up at the top of the slide, you'll see that dotted line is separating the dorsal rami on the left, on the far left side of the slide, from everything else, which is all ventral rami. So that one vertical dotted line on the left side is representing that boundary between dorsal rami on the left and ventral rami on the right. A couple of the dorsal rami are so unique in their course, in other words, so unique in the way they travel and the structures that they innervate, that we actually give them names. And you might not remember it, but you've already seen these before. So the dorsal ramus of C1 is called the suboccipital nerve. That's the nerve that passes between the 3 muscles of the suboccipital triangle: rectus major, superior oblique, inferior oblique. And it's what's responsible for innervating all 3 of those suboccipital muscles at the back of the neck. The dorsal ramus of C2 also gets a special name. It's called the greater occipital nerve. And you saw that also back in that suboccipital area, but the greater occipital nerve does not go through the triangle. It actually exits inferior to the inferior oblique muscle, and then passes through some of the other neck muscles like semispinalis capitis and ends up on the back of the scalp. And you were actually supposed to look for it on the very first day of dissection when you were skinning the back of the scalp. It's a sensory nerve to the back of the scalp, the back of the head. After C1 and C2, then the rest of the dorsal rami are just called dorsal rami. Dorsal ramus of C3, dorsal ramus C4, they don't get fancy names after that. And they're responsible for innervating things like the deep back muscles, like erector spinae, etc., and also sensation from a narrow strip of skin down the middle of the back. Now, everything to the right of that first dotted line are the ventral rami. But then there's another vertical dotted line and another division or another separation. The structures in the very center of the diagram between the 2 dotted lines represent what we call the posterior branches of the ventral rami. So it's all ventral rami, but the ventral rami split into posterior and anterior branches. We have posterior branches of the ventral rami from C1 through C4 that join together to form something called the cervical plexus. And this is a group of sensory nerves. They are entirely sensory. The posterior branches of the ventral rami are all sensory. These are the nerves that kind of spread out across the sternocleidomastoid, and they're responsible for sensation from all of the skin of the neck. And they're all abbreviated in the diagram, but then there's a little box down here with a key. So lesser occipital is the nerve that runs up along the back of the sternocleidomastoid, and it's sensory to an area of skin behind the ear. Great auricular is abbreviated GA. That's the one that runs across the outside of sternocleidomastoid, usually running with the external jugular vein. That's also sensory to an area around the ear. The abbreviation TC is transverse cervical. That's the branch that travels anteriorly to supply all of the skin at the front of the neck. And then there's this little fork here, these three little forks, abbreviated SC. Those are these supraclavicular nerves that travel down towards the clavicle and are responsible for sensation from the lower part of the neck, basically, where the neck and the clavicle and the thorax all meet. Okay, so the cervical plexus is formed from these posterior branches of ventral rami, which are entirely sensory. And finally, the structures to the far right, to the right of that second dotted line, are the anterior branches of the ventral rami. And these anterior branches are all motor. No sensory component to them. And if we look at the anterior branch of the ventral ramus of C1, that's the one that is going to hitchhike along the hypoglossal nerve. It's not really part of hypoglossal. It just kind of attaches to it, travels with it for a short distance, and then splits away. And that's what forms the superior root of the ansa cervicalis, supplying innervation to most of the strap muscles, the infrahyoid muscles. And then the anterior branches of the ventral rami of C2 and C3, shown here where I'm circling with the cursor, they join together and travel down to form what's called the inferior root of the brachial plexus, of the ansa cervicalis. Now, if you actually see the ansa cervicalis and you see this loop, when you see the two roots side by side, it's hard to tell that one's superior and one's inferior. Really, one's more anterior and one's more posterior. But the superior root is called superior because it's derived from a higher spinal nerve level. It's coming from C1. Inferior root is called inferior because it's derived from lower spinal nerve levels from C2 and C3. Yeah.
It's not because like they split off, it's higher at the superior and lower.
I think it's just because of their origins from different spinal nerve levels. And you'll notice that there are a number of branches coming off of the ansa cervicalis at various points, and these are the branches that supply the most of the infrahyoid muscles, like sternohyoid and sternothyroid and so forth. And then final thing that's shown on here, which you won't actually see in lab, so you don't have to worry about it too much, but we will come back and see it later. Here's that phrenic nerve coming from anterior branches of C3, C4, and C5, all joined together. And then running down along the anterior scalene muscle very deep in the neck, continuing through the thorax to innervate the diaphragm. And then there is another little label on here with a bracket just showing that after that, then you start getting into the brachial plexus. Right? You start getting into C5, C6 forming superior trunk, C7 forming middle trunk, C8, T1 forming inferior trunk. So there's a little bracket here just identifying the trunks of the brachial plexus. All right, last thing I want to talk about today are the arteries that you're going to see in the anterior triangle of the neck. And you've already seen some of this diagram before, showing the origin of the vertebral arteries, how they travel up into the head through foramen magnum, showing the common carotid arteries and how they split into internal and external carotids. But there's a bit more detail here. So starting down in the thorax, eventually you're going to get a subclavian artery and a common carotid artery down in the thorax. Now, remember, there's a difference between left and right sides. In this case, we're looking at the right side of this person's body, but we don't see the brachiocephalic artery here. It should be there. It's actually just a little, it should be a little deeper. It's kind of hidden by the clavicle in this view. But on the right side, there'd be a brachiocephalic artery that would split into right subclavian and right common carotid. If we were looking at the left side of this person, the left common carotid and the left subclavian branch directly off the aorta. There's no brachiocephalic artery on the left side. The subclavian artery gives off a branch called thyrocervical trunk, which we'll see later in lab. And that's what gives off this transverse cervical artery and suprascapular artery. They showed up on a slide I showed you earlier today of the posterior triangle of the neck, but you probably didn't see these in the posterior triangle. We'll come back and we'll dissect those another time, when we do a deeper dissection of the neck. There's another little branch here called inferior thyroid artery, which is also coming off that thyrocervical trunk, off the subclavian. That's supplying blood to the thyroid gland, but we'll see that again later too. Vertebral artery you can't really see in the neck because it's actually hiding within the transverse foramina of all the cervical vertebrae, but we did see it on the brains, because it continues up through the foramen magnum to contribute to the circle of Willis. So let's focus most of our attention on the carotids then. So we have a common carotid artery that comes up into the neck, and then the common carotid enlarges right about the point where it's going to bifurcate. And the internal carotid artery branch sits more posteriorly and does not give off any branches in the neck. The internal carotid is going to enter the skull through the carotid canal, and it's only going to give off branches once it reaches the circle of Willis on the base of the brain. Internal carotid doesn't give off any branches here in the neck. All of the branches to the neck and the face are coming off of the external carotid artery. And that's really what we're going to be focusing on in lab today, or one of the things you're going to be focusing on in lab. So the very first branch off of the external carotid is an artery called the superior thyroid artery. You'll see it coming off the external carotid and then turning inferiorly down towards the thyroid gland to bring blood down to the thyroid gland that sits down here in the neck. The superior thyroid artery in turn gives off a small branch called superior laryngeal artery, which is actually going to poke into the larynx. It's going to pass through a membrane between the hyoid bone and the thyroid cartilage to bring blood to the interior of the larynx. And again, RIT tries to take over my computer at the last moment. Okay. So superior thyroid giving off a smaller branch called superior laryngeal. Then continuing to work your way up the external carotid. Next branch we should come to is called the lingual artery. That may be pretty tricky to find because often it's much higher up and it's kind of hidden behind the ramus of the mandible. So you may have to dig pretty deep behind the mandible to see this. But lingual artery is going to travel forward and go into the tongue to supply blood to the tongue. Then very close to where the lingual artery branches off, we'll find the origin of the facial artery. In fact, sometimes lingual artery and facial artery share a common origin and then split apart later. But facial artery is pretty distinct because it dips down around the angle of the jaw and then crosses diagonally across the face. And sometimes, just as it's passing around the angle of the mandible here, it's frequently embedded within the submandibular gland, the salivary gland that some of you saw down around the corner of the jaw, the angle of the jaw. And then some of you also saw the facial artery on our first day of dissection when we started the face, when we skinned the face. Some of you may see like a couple little loops of the artery as it crosses near the cheek or up towards the nose. So you'll be looking today for superior thyroid, superior laryngeal, lingual, and facial arteries. The other branches we'll come back to later. You won't see any of these today. If you were to follow the external carotid up towards the skull, it actually ends, external carotid ends where it splits into these last two branches. There's a superficial temporal artery supplying blood to the sides of the head, to the outside of the head. And then there's a maxillary artery that turns anteriorly and actually kind of disappears into the maxilla from behind. But we'll see those later. At some point after this next exam, we're actually going to remove the upper part of the mandible and look deeper into this area, and that's where you'll be able to see the end of the external carotid where it splits into superficial temporal and maxillary arteries. So you've seen this picture before, but this is supposed to show some of those arteries. So here's your common carotid coming up, and then it bifurcates right about here. Internal carotid is more posterior, doesn't give off any branches in the neck. External carotid is more anterior, and you see its first branch right here called superior thyroid, which is now turning inferiorly down towards the thyroid gland, and tiny little branch called superior laryngeal, which is passing through the membrane between the hyoid bone and thyroid cartilage to enter the larynx. Here's lingual artery, which you can only see for a short distance, and then it disappears into the tongue. And then facial artery, you can only see it up here, at least in this slide, as it's beginning to cross the edge of the mandible and continue up into the face. So we're right out of time basically, but any questions about anything from today or any last minute questions about Monday's exam? All right, see you in lab shortly.